Now we move on to the next one. We have Dr. Parag Biniwale, who's a very dear friend. He is a consultant from Pune and he will speak on postmenopausal bleeding. And he is a senior consultant at OB-GYN Pune, PG teacher and unit head of Kamla Nehru Hospital. He is president of the Pune OBGYN Society and he is vice chairperson of ICOG now 2021-23. And he is now secretary of ICOG. He was from 2018 to 20, national website editor Foxy, peer reviewer of the Journal of Obs and Gynae from 2011 to 17. It goes on and on. We welcome you, Dr. Parag, for your talk on postmenopausal bleeding.
Good afternoon. I bring greetings from Pune, and it's indeed a pleasure to be part of this very interesting program, MMLCON. And let me thank Dr. Ragini Agarwal and team of HARoBGyn for having me here. In next 15 minutes, I'm going to talk about postmenopausal bleeding, which is a problem which poses a lot of challenges to some women. Now, what exactly is postmenopausal bleeding? We know that menopause is when a woman stops menstruating for a year. So anytime after that, if she starts bleeding again, we say that she has postmenopausal bleeding. As per Indian Menopause Society, the incidence of postmenopausal bleeding is about 10 to 15%, while world over it is presumed that the incidence of postmenopausal bleeding is about 4 to 11%. And when we talk about various causes of postmenopausal bleeding, we can see that atrophic endometritis and vaginitis are by far the most common conditions where women tend to bleed. But let's not forget the hyperplasia and carcinoma, which may be there in some women. Now, we know that why atrophy takes place, and after menopause, we know that the ovarian function declines and leads to hypoestrogenism. Hypoestrogenism by itself causes atrophy of the endometrium and the vagina, and sometimes these atrophic tissues start bleeding. The second concern about this particular condition is possibility of cancer. And when we talk about a cancer in a postmenopausal woman, it generally refers to endometrial cancer. We know that when the endometrial thickness is less than 4 millimeters, it is unlikely to be having cancer. But in women who is into menopause, especially after the age of 55, and who has had recurrent episodes of bleeding, and if the volume of the bleeding is exceeding 5 pads per day, it is postulated that there is a possibility of endometrial cancer. Let's not forget the other causes, and polypi, though more commonly seen in younger women, but even in postmenopausal women, the polypi or the growths can be responsible for bleeding. And let's not forget estrogen therapy or tamoxifen. Endometrial hyperplasia is one condition which typically presents with bleeding, and even in postmenopausal phase, it is still possible that women may experience some amount of bleeding. And here, let's not forget that endogenous estrogen production from ovarian or adrenal tumors or exogenous estrogen therapy are also possible causes. And especially in obese women, we have to remember that endogenous estrogen, due to conversion of androstenedione to estrone, may result into endometrial hyperplasia. Leiomyoma uteri, again, something which is common to little younger age group of women, but some postmenopausal women may come to us with bleeding. Adenomyosis, diseases of adjacent organs like diverticulitis should be kept in mind. And let's not forget the other organs, which include urethra, bladder, and bowel. And women who undergo radiation therapy may at times present with vaginal bleeding. Anticoagulant therapy, infections like endometritis, or even herbal or dietary supplements are rather rare causes of postmenopausal bleeding. So when such a woman comes to us, it is important that we take history, ask her the age of menopause, when the bleeding started, Were there any precipitating factors? Was she taking any medications? Is she on the soy containing or herbal or dietary supplements? And not to forget, family history of breast, colon, or even endometrial cancer. So we have to be on guard, especially when the woman in question is obese, has diabetes, and even women who take tamoxifen are certainly at high risk for developing endometrial hyperplasia and eventually endometrial cancer. We must ask for history of vaginal dryness and soreness with dyspareunia, and bleeding after intercourse may suggest atrophic changes. And let's not forget a foreign body in some women, which could be responsible for some amount of bleeding. Examination is extremely important, starting with BMI, blood pressure. Dental local examination is very, very important. We have to put in a speculum to have a look at the vulva, cervix, vagina, so that we rule out atrophic changes. And we must also look for bleeding to anus or even urethra. Coming to the investigations, and these are the typical investigations which are recommended to all women in menopause or in postmenopause who come to us for a routine checkup. So the women who with postmenopausal bleeding should be subjected to these. But coming to specific investigations, the first and foremost is cervical cytology, and here we are more focusing on the endocervical sample because we want to rule out atypical cells in the smear. So here, atypical cells may denote that we are dealing with a woman who has endometrial pathology. So if the cytology shows presence of AGC, which is endometrial cells, presence of AGC in all subcategories other than endometrial, if the woman is more than 35 years of age, or presence of benign appearing endometrial cells in a woman who's more than 40, we have to think of doing a biopsy. What is the role of an ultrasound? Transvaginal ultrasound is by far the best. It will help us to determine the uterine size, endometrial thickness, which is so important in women after menopause. Cutoff of 4 is something we have to keep in mind. Polypi must be ruled out, and we should also look for other pelvic pathologies. 3D ultrasound has limited role, while intrauterine pathologies are better diagnosed with saline infusion sonography. Coming to the endometrial thickness, and the IMS guidelines 2020 say that if a woman comes with postmenopausal bleeding with endometrial thickness of less than 3 to 4 millimeters, this does not require endometrial sampling unless there is a high risk of EC or if the bleeding is episodic. But if the endometrial thickness is more than 11 millimeters, it should prompt an endometrial biopsy. And of course, if the thickness is in between, these women do need repeated surveillance. So transvaginal ultrasound definitely plays an important role in screening women who have postmenopausal bleeding, and greater prevalence of fibroids and non-endometrioid type 2 endometrial tumors in a certain group of women may contribute to this disparity. Now, coming to endometrial biopsy. So when the endometrial lining is thicker than 4 millimeters, or when the endometrium shows diffuse or focal increased echogenicity, or if the endometrium is not adequately visualized on sonography, we should think of doing an endometrial biopsy, or especially if the woman who has persistent bleeding, we may be dealing with a woman who may have endometrial cancer. So what is the next step that we do? So we can think of doing a PIPEL biopsy on an OPD basis, especially if you're not contemplating any intrauterine pathology. Outpatient hysteroscopy is the preferred method for endometrial sampling, so that you have a look at the endometrial cavity and take directed biopsy. And recurrent episodes of bleeding warrants further investigations, and this is something which we have to keep in mind. All of us are aware about the PIPEL, and minimal to no cervical dilatation is required, no anesthesia is generally required, and the procedure is done in about 2 to 3 minutes. How effective is it? There are quite a few studies which talk about it, and it is noted that less than 5% patients had insufficient or no sample. It means that 95% women had adequate sample, and the sensitivity was thought to be 99.6% in postmenopausal women. So this comes as probably the first diagnosis when you want to detect some pathology of the endometrium. Hysteroscopy has its own advantages. We know that it's highly sensitive, it has better accuracy, but it all depends on the skill and experience of the operator. And let's not forget the cost that is involved with hysteroscopy. So whenever we are dealing with a woman who has postmenopausal bleeding, we have to consider hysteroscopy, and the Indian study talks about safety and efficacy of hysteroscopy, and they recommend that it should be first line gold standard method for the evaluation of endometrium. And when we put in a hysteroscope, this is something which we may come across, and we have to really take a guided biopsy to make a diagnosis. Atrophy is something which is probably the most common, and here women report to us with vaginal dryness, pruritus, dyspareunia, etc. Urogenital atrophy is a result of declining estrogen levels and may also present with recurrent urinary tract infection. Diagnosis is simple. We just put in a speculum and make a visual diagnosis. Coming to the management, and vaginal lubricants and moisturizers may be offered to women who have vaginal dryness or dyspareunia, but local estrogen therapy is the gold standard. Of course, let's not forget the lifestyle modification that is so important. So whenever we think of local therapy, it is indicated for women who come to us with postmenopausal bleeding due to urogenital atrophy. Vaginal estrogen therapy is the most effective, and there are so many formulations that are available. The Indian Menopause Society recommends use of estriol cream, or even oral estriol, or even conjugated equine estrogen in cream form or even oral form. And this is what the therapy includes. Systemic therapy does have some role, but literature supports local therapy in a much bigger way. So this is the checklist to diagnose genitourinary syndrome of menopause when women come to us with postmenopausal bleeding. Coming to CA endometrium, and we all are aware about the risk factors that may be responsible for CA endometrium. And the Indian Menopause Society recommendations or the assessment of risk factors is something which we have to keep in mind. There are certain modifiable risk factors: obesity, diabetes, hypertension, PCOS, or even unopposed estrogen. There are some non-modifiable factors, and it is really important for us to understand these, because we can certainly control the modifiable factors, which may in the long run help the woman from not developing endometrial cancer. And this is the FIGO staging for endometrial cancer with a 5-year survival. So the earlier the diagnosis, better are the chances of survival. What about the imaging techniques? Ultrasound, yes, it is extremely important. MRI is also considered to be a very good modality. It will tell us about the myometrial invasion. It will talk about lymph node metastasis as well. So PET scans have utility in detecting occult lesions. Here, we also have to remember that a chest radiograph should also be performed as a part of initial assessment. And when we talk about endometrial carcinoma, this is the standard recommendation or the surgical management. And here, the surgical management would include exploratory surgery, which could be laparotomy or laparoscopy. Peritoneal washings are important, and when we think of doing a hysterectomy, bilateral salpingo-oophorectomy is done, and of course, lymphadenectomy has its own place in management of endometrial cancer. These are some of the important points we must remember, that surgery constitutes definitive primary treatment for most patients of endometrial carcinoma. Primary radiation therapy and primary hormonal therapy are alternatives for women who are inoperable as far as surgery is concerned, and women who with low risk endometrial cancer, no additional treatment is required after surgery, because the oral and injectable progestins also are acceptable therapeutic options that we have. But here we have to remember that periodically the endometrial assessment has to be done, and endometrial sampling may be required every 6 months. Coming to surgical treatment. So women who have endometrial hyperplasia without atypia, we can think of offering them all sorts of modalities, which include medical treatment or even endometrial surveillance. But women who have endometrial hyperplasia with atypia, hysterectomy is by far the important therapy. SOGC, of course, recommends to avoid subtotal hysterectomy and morcellation in cases of endometrial hyperplasia. So this is something which all of us have to remember. And cancer cervix could be a cause of postmenopausal bleeding or even postcoital bleeding, and examination will be of great help, and biopsy has to be done to confirm. Primary goal is the diagnostic evaluation of postmenopausal women with uterine bleeding is to exclude malignancy. Endometrial biopsy, transvaginal ultrasound can be used as initial testing to evaluate the endometrium. Usually light and self-limited exclusion of cancer is the main objective. Therefore, treatment is usually unnecessary once cancer has been excluded. And these are the guidelines of Indian Menopause Society, where MHT should include a progestogen containing regime which is protective against endometrial effect of unopposed estrogen. Office endometrial biopsy should be first line investigation in workup of postmenopausal bleeding, and hysteroscopic guided biopsy is the gold standard. Hysteroscopy and biopsy is the preferred diagnostic technique to detect polypi and other benign lesions, and D&C per se should no longer be used as the first line method of investigating postmenopausal bleeding in most cases. Thank you very much. And once again, thank you, Dr. Ragini and team, for having me here.
Thank you. Thank you so much, Dr. Parag. So moving forward, the next, I will invite the next chairperson, Dr. Kiran Pandey. So Dr. Kiran Pandey is the chairperson, Medical Education Committee, FOXY, and she is the ex-HOD Department of OBGYN, GSVM Medical College, Kanpur, Vice President UPCOG, Vice President UPAGI, past President Kanpur OBGYN Society and IMA, and presently she is the President Kanpur. She can sum up the session. Meantime, I will introduce Dr. Indu. She is the best cancer specialist in Gurgaon, and she's a radiation oncology head in Narayana Super Specialty Hospital. And not only that, she is a very good poetess also, and a very good human being, and vast experience in the radiotherapy. Over to you, Indu, for continue your lecture. And Dr. Kiran, I will request you to sum up the whole session.
Good afternoon, everyone. And first of all, I would like to thank Dr. Ragini ma'am and all the organizers for making me a part of this wonderful session. And I've been listening to a few of the talks from my previous speakers. And I think as all of us are heading slightly towards, not all of us, I mean, few of us are heading towards menopause. So I'm finding these sessions really quite interesting. So and thanks for giving me the chance to speak on cancer. I think that a few minutes that I'm going to speak is going to be a very, very important and a very informative session, because as doctors, I feel that we as doctors, we keep on neglecting our health the most. We will take care of everyone around of the patients, but if we really talk, how many of us do get our mammograms done or get our pap smear done? So that is what I'm going to talk about. So can you and me do something to prevent cancer? That is the topic for my talk today. So we all know that cancer is the second main cause of mortality. And if you would be really surprised to know that in India, as of 2022, there are around 14.6 million cancer cases, and unfortunately, 9.6 million, or more than 50% patients, they die. And 1 in 9 women and 1 in 9 people are at risk of cancer. And unfortunately, this risk is going to increase by 12.8% by 2025. Means in another just 3 years, these numbers are going to increase by 12.8%, which is a very, very alarming figure. So we must understand what causes cancer. It's caused by both internal factors as inherited mutations, hormones and immune conditions, but also by environmental acquired factors as tobacco, diet, radiation, and other infectious organisms. But what we tend to ignore is that only 5 to 10% of cancers are due to inherited gene defects. But our lifestyle and environment, they account for 90 to 95% of chronic illnesses, including cancer. And although all cancers are a result of genetic mutations, these mutations are a result of interaction with the environment. So definitely we need to do something about it. So can you and me do something to change these figures? That's why I'm here today. So, as I said, that genetic factors, they account for only 5 to 10% of the cancer risk, and environmental factors, they're responsible for 90 to 95% of the cancers. Among the genetic factors where the genes are responsible for cancer, we all know that thyroid 8.5%, testicular cancer 8.6%, breast cancer 1.8%, melanomas, we see prostate cancer running in families, renal cell cancers, colorectal cancers, lung and multiple myeloma. But rest of the tumors, they are caused due to environmental factors, like tobacco is responsible for 25 to 30% of all cancers. Faulty diet alone is responsible for 30 to 35% of the cancers. And alcohol, in fact, today only there was a newspaper article which tells that no drop of alcohol is safe. It is responsible for 4 to 6% of cancers, obesity for 10 to 20% of cancers, and infectious agents 15 to 20%. So we must understand what do we mean by first degree relatives, and we must know our cancer risk. So first degree relatives are parents, siblings and offsprings. So अपने घर की जन्मपत्री, कैंसर की जन्मपत्री बताना बहुत जरूरी है, रिश्ते मिलाना बाद में, बट पहले हेल्थ जन्मपत्री मिलाना बहुत जरूरी है आज की डेट में. So there are certain hidden truths behind cancer which nobody talks about. 4 in 10 cancer cases can be prevented. And how we are going to do that, that I'm going to talk. So we have to change today's lifestyle to prevent tomorrow's cancer. Coming to smoking. In 1964 itself, smoking was identified as the main cause of lung cancer because it is at least 50 carcinogens, and tobacco alone increases the risk for 14 types of cancers. Compared to non-smokers, male smokers are 23 times and female smokers 17 times more likely to develop lung cancer. So for all my female audience here, I want to emphasize that even if males smoke more or they may take more alcohol, but for the same amount of alcohol or same amount of cigarettes, females will be more at risk of developing cancer. So smoking alone accounts for 25 to 30% of deaths from cancer and 87% of deaths from lung cancer because it can alter a number of cell signaling pathways and can induce activation of NF alpha beta and inflammatory marker. So I read that very interesting article sometime back, how many cigarettes are there in a bottle of wine? I really found this heading quite catchy because some people feel that because they're not taking cigarettes or they are not taking tobacco, so someone calculated the cigarettes to a bottle of wine. So what it means is that smoking and alcohol are more hazardous than we think. Smoking alone can lead to cancer anywhere of the aerodigestive tract, like from oropharynx to larynx, esophagus, stomach, pancreas, renal parenchyma. Then in females, it is responsible for cancer of the cervix, vulva. For males, it is responsible for cancer of the penile area, bladder cancers, renal cancers, anal cancers, and pancreatic cancer. So all around 16 sites of in the body are caused by tobacco consumption alone. And if someone is taking alcohol, then it leads to risk of six sites of cancer. Oropharyngeal cancer risk increases by 21% in males. Liver cancer increases by 18%. Breast cancer risk increases by 3%. Esophageal cancer risk increases by 14%. And in fact, laryngeal cancer also increases by 21%. So, and I recently wrote an article on gutka because many people talk about smoked tobacco, but are we really creating a lot of awareness about the smokeless tobacco? Because the government has tough legislation against smoked tobacco. So now more and more pharma companies, more and more companies are coming up with pan masalas and gutkas, और उनको pan masala करके flavored करके बेच दिया जाता है. So please see that this is the 4th most common psychoactive substance which is consumed globally. It has 4,200 chemicals, out of which 28 are carcinogenic. So the gutka has typically crushed areca nut, tobacco, catechu, paraffin wax, slaked lime, जिसको चूना बोलते हैं, and nicotine to make it addictive. And it is the most common cause of oral cancers, which takes lives of very young men and women in their most reproductive age group, and it leads to a very mutilating surgery as well. So I have given it the name as the suicide masala. Now, how safe is alcohol? If someone is taking alcohol, then there is 7% risk of breast cancer with consumption of only 10 ml per day. Liver and bowel cancer, if 50 to 70 gram per day. Even up to 2 to 3 drinks per day leads to 8 to 23% risk of prostate cancer, 25 to 68% risk of upper aerodigestive tract cancers. And if HCV infection and alcohol intake both are combined, then the risk of hepatocellular carcinoma goes up by 2 times. And we see many cases of liver cancers these days, and I'm seeing almost 1 patient a week these days with hepatocellular carcinoma. So alcohol is responsible for 3.5% of all cancer deaths, 5.5% of all new cancers, 5.8% of all cancer deaths, and cancer of 7 sites in body. So if someone is drinking 3 bottles of wine per week, it is equal to smoking roughly 17 cigarettes for men and 23 for women. I want to repeat this again. If someone is drinking 3 bottles of wine per week, it is equal to smoking 17 cigarettes for men and 23 cigarettes for women. Now coming to obesity. All of us are becoming couch potatoes, and obesity alone is responsible for 14% of cancers in males and 20% of cancers in females. So what all cancers are associated with obesity? So all cancers of the digestive tract, like colon cancer, gastric cancer, gallbladder cancer, liver cancer, rectal cancer, pancreatic cancer. Apart from that, ovarian cancer, uterine cancer, cervical cancer, breast cancer, endometrial cancer, colon cancer, esophageal cancer, renal cell cancer, non-Hodgkin lymphoma, multiple myeloma, they are all caused by obesity. So this is because of involvement of signaling pathways as IGF, AKT signaling pathway, the leptin, JAK-STAT pathway, and other inflammatory cytokines which are linked with obesity and cancer. So we had a physiotherapy talk just before my talk. So I think this is very, very important that we take care of the waist abdominal, of the waist circumference, and not just BMI, and be more proactive. Now coming to diet. 30 जो हमारे मुंह के अंदर जाता है वो डिक्टेट करता है कि कल को हमारी बॉडी के साथ हमारा क्या होने वाला है. So faulty diet is responsible for 35% of cancers, including it increases the risk of larynx cancer, mouth, pharynx, esophageal cancer, lung cancer, gastric cancer, pancreatic cancer, colorectal cancers, gallbladder cancers, prostate cancer, endometrial cancers, and breast cancer. So please consult a dietitian, make a diet chart, and start regulating what goes inside your mouth every day and what is in their kitchens. So what are the superfoods to prevent cancer? I've given them an acronym that is known as G bombs, or just to remember it, green bombs. G stands for green, B is for beans. So any family of any vegetable of beans family, chahe koi bhi phaliyan, they are protective. Onions, mushrooms, berries, सारे बेर फैमिली के फ्रूट्स, सीड्स, जितने भी pumpkin seeds हैं, pumpkin seeds और जितने भी seeds हैं वो सब प्रोटेक्टिव होते हैं. विटामिन्स एंड सिट्रस फ्रूट्स. सो खट्टे फ्रूट्स जितना भी, जैसे अंगूर है, अमरूद है, संतरा है, मौसमी, kiwi, all these are very, very protective. So try to include lots of fruits and vegetables in your diet. Try to have as much as color and variety in your plate as you can. So एक fruit उठा के खाने की बजाय better to have a fruit platter.
डॉक्टर इंदु थोड़ा समराइज कर लीजिएगा.
बस मैम, about to last slide. Almost last slide. So infection and cancers, we all know that HPV related cervical cancer, then hepatocellular carcinoma is HCV related. And then exercise, we all know that it helps because prostate cancer, melanoma, colon cancer, breast cancer, the risk decreases with if a person who has been diagnosed with cancer, they keep on exercising, then the risk of disease recurrence goes down. And we all know that a lot of household products, they also lead to increased risk of cancers. From chips to perfume, there are a lot of carcinogens in this. And recently we had an article in the newspaper mentioning about these sanitary pads, which leads to increased risk of cancer because they have phthalates and volatile organic compounds, which can increase the risk of breast cancer, and they are endocrine disruptors. So cosmetics also, we have to be really very, very look into what we are using. And we also know about the risk of plastic containers. So because I have to wind up, so I know, and stress also leads to speed up of cancer. It leads to telomere shortening. So better to remain stress-free. That's all I have to say. And we just successfully treated 1,000 patients on our TrueBeam machine. So I just want to thank each and everyone who had faith in me and for all the patients for supporting us. Thank you so much.
Thank you, Dr. Indu. It was a very, very nice and elaborative lecture. You have talked of so many carcinogens which we are using in day-to-day life and which are very important. And the very important thing, which, as you said, that even I read that article, that even a few drop, alcohol is not safe at all in any amount, which the people do think this much is there. And it was a very different type of things which you have taken all the cancer risk, not only the genital cancers, which we are basically talking. So basic thing is we have to have we can't avoid each and everything. I mean, on a practical ground, if you come to that, but we should try to use as much as possible our homemade food, our homemade things, even in cosmetics. Our nani dadi used to use that malai, and their skin was always good up to the end, and their eyes were good, their teeth were good, which we have probably under the Western influence, we have dropped those habits, and that is the result which we are facing it. And very nicely you said that non-smoking and gutka and other things. So I hope everybody will take care of their health. Besides taking this, exercising is very good thing. I hope the message is clear to the audience.
Thank you so much, Dr. Kiran and Dr. Indu. So it is something beyond carcinoma cervix and carcinoma breast, which we have to look for. So moving forward, I will invite Dr. Kavita Bhati. She is the professor and HOD OBGYN, Christian Medical College and Hospital, Ludhiana, and she is president of the Ludhiana Menopause Society. And she's deputy hub lead Global Surgery Research Collaboration University also. Many achievements and award. Over to you, Dr. Kavita Bhati, to introduce the next speaker, Dr. Jamuna.
Thank you, Dr. Ragini ma'am. And before I introduce the next speaker, I want to thank Dr. Ragini ma'am for giving me this opportunity. Congratulate also, because it has been a really interesting webinar. So with very wonderful topics, and all of us have benefited. And we have been listening since morning to such wonderful talks. So thank you, ma'am, and congratulations.
Thank you.
Our next speaker is Dr. Jamuna Devi. She is a senior consultant obstetrician and gynecologist at Yashoda Hospital, Secunderabad, and she's also a medico-legal advisor. She has specialization from Katia University, Warangal, post-graduation from Osmania University, Hyderabad. And we welcome you, ma'am, for today's talk. So
Thank you.
Dr. Jamuna Devi speaking on IMS at 70 plus.
Thank you so much. I think it was wonderful listening to so many people about the various issues of exercise, diet, cancer risk, and all those things. But I must appreciate that the 70 plus club committee, which is the brainchild of our president, Dr. Shobhana Mohandas. And I think after that, I think although we all go to these old age homes during our, in memory of father, mother, or, birthday of a child and all those things, but we used to go with just something like, okay, jana hai, kuch dena hai, karna hai, bas. But now after this 70 plus club committee, I think we have taken it as a challenge, not only just visiting them, but spending time with them, understanding about them. And Ragini, you have actually motivated all of us to visit these homes. And I think most of the societies have taken it and they have done it. And I think it has given intense satisfaction and happiness to all of us. And actually in olden days, what we used to see is like life was very simple and values were counted. And those who have reached their age, they had a very happy place in the family and in society. People used to respect them and they will spend relaxed, enjoy their twilight years, and their knowledge was respected in the family and the society, and they always commended their attention and respect and affection. But this is the past. What is the present? We talk about that successful aging is defined as the ability to maintain low risk of disease or disability, high mental and physical function, and active engagement with life. But during this changing world, is it happening? And when I was going through these literatures, I found that there is United Nations International Day for Elderly Persons. And in 2022, they have coined a theme, resilience of older persons in a changing world. And they have celebrated by NGO committees on aging. This is something new. And why we actually celebrate these international days and weeks? Because it's an opportunity to educate the public on with this concern. And not only that, we can mobilize the political will and resources so we can address this global problem. And when we celebrate and reinforce these achievements of humanity, it gives an immense pleasure. And then existence of these days, international days, will embrace as a powerful advocacy. And this we have seen in other like International Menopause Day, Osteoporosis Day, and also on. What is the objectives? The highlight of this resilience of older women in the face of environment, social, economic, and lifelong, there are inequalities. And we have to raise awareness of the importance of improved worldwide collection and disaggregated by age and gender. So they have called on the member states, UN entities, UN women, and civil other societies. So they said that we should include older women in the center of all policies so that we can ensure equality. So far all the speakers have talked about how fast the aged population is going to increase. So I will not repeat it, but definitely I will tell that it will be doubled by 2050. And it's really scary. And India is not going to be behind. We also are going to be, by 2020, we see 149, which is a tremendous increase. And by percentage, it is 12% in India. And world population, imagine that's from 6.1 billion in 21st century is going to become 9.3 billion in 2050. And age population is going to 2 billion, which is 4-fold increase. So in terms of proportion, it is 10% in 2000 and it is rising to 21% by 2050. This is really scary. And what are the facts? So 24 million in 1961, they have increased to 77. And now what is the projection? From 179 in 2030, it's going to be 300 in 2050. So 70 and above projected to increase from 29 in 2001 to so many millions in 2050. So 80 plus would be fastest to grow, 8 millions to 32 million. This is the, I think, menopause society was taking care of menopausal and postmenopausal, but now I think we have to extend our yardstick and our area to this geriatric group also. So India is the second largest elderly population in the world, and 80% are in rural, 40% below poverty line, and 73% are illiterate, and 90% of the old, they have no official social security because they are not employed. So no PF, no gratuity, no pension. So now why all this is happening? Because we have seen that there is a change in the family structure. We have become nuclear or unit, just small unit families. And there is no safety or security or dignified status in the family. So the elderly are finding themselves very vulnerable. Then the welfare of the elderly has been a very low priority even in the state and the government policies. So what are the social issues which affect this elderly? Loneliness from losing a spouse and friends. Actually, we have experienced when we went to one of the home, there is one person, male person, who was in his 60s. He just retired about 2 years back or so from the government service and railways. And then he was in a home with the other elderly and the disabled and sick people. So we were just wondering, I asked him, why you are here? Because he was very well physically fit and all that. Because the family was unable to have him with them, the son and daughter-in-law, and I think they have a child. So he had to leave the home and join a home for the aged, which is very sad. And such people, I think, should be, encouraged to start something or live, at least taught to live on their own. Inability to independently manage regular activities of living, difficulty coping up and accepting physical changes. Then there is a frustration with all these medical problems, increasing medications. And we have seen that social isolation as adult children are engaged in their own work, even if the elderly is at home, then feeling inadequate from inability to continue to work, and they have to become dependent on others for their own work. Then there is a boredom from retirement and lack of routine activities. So financial stresses from the loss of regular income, which is a major cause of loneliness. So what is the support? So the major thrust has been on improving the health status of these women. There are no geriatric services. There are 186 old age homes, 233 daycares, and so many vans, but still we need a lot of them, because when we went to the homes, they are fully occupied and they don't have space, but they do get a lot of women, destitute women, men, coming back to their homes. And most of the time they are managed by the NGO network of PHC and subsidiaries. And this need to be expanded. And unfortunately, most hospitals, they don't have a special geriatric facility. They have to go through the general medical wards. And there are few hospitals in India, those who give postgraduate education in geriatric medicine, which is very much needed. Then similarly, even the nursing and other paramedical staff, they're not formally trained in providing care for these elderly. And this training is required. So actually, no one is terrified about growing old, but the terror is in becoming clinically dependent. So the aging is pattern of life change. All of us know that occurs, but gerontology is the study of individual and collective aging process. So they have biological, psychological, social, legal, functional age groups. So how do we say that there is a successful aging? Only when it is maintained desirable weight, optimal nutrition, regular exercise, regular health checkups, treat conditions as appropriate, avoid toxic exposures. So in summary, elderly population in India, we have seen that it is increasing tremendously, and status of elderly changing in the family. Geriatrics is in incipient stage. NGOs have important role to play in creating awareness and imparting information, and they can train of supportive services. And we need to learn from the model of geriatric from the developed countries. So these are some of the pictures where we have gone through. And I must say that I could not include all the pictures of all the societies because lack of time, but most of the societies have done their bit. And I must share these policies because we should know when we are talking to some geriatric or we are going to homes, probably we can share these or we can have it them in our clinics so that an elderly who comes to our clinic for a visit, they would know what are the initiatives or policies which are supporting them. So this is from the Indian government, National Council for Older Persons. It's the responsibility of the state and central. And it is known as Maintenance of Parents and Senior Citizens Act. And now here, this is a nice project which is launched by Ministry of Social Justice and Empowerment. And it's a very good initiative. And they are taking a step toward generating skilled and committed human resource. This is very important for elderly care. And but its awareness is not so high among the students or the professionals if they are interested to do so. Integrated programs for older persons. This is very interesting because this program, they give financial assistance to the NGOs to establish homes for the poor and destitute. But then they have to give a project report to these people. Then what is the aim of these policies? This is only to encourage geriatric units in hospitals, clinics, and care, infirmary care units. Then not only that, I think as IMS, we can start emphasize on family care of the aged through incentives and schemes for the needy family. Of course, incentives we can't give, schemes we can't give, but at least we can give an awareness programs or lectures to the families. Promotion of values through formal education and media, then subsidizing old age homes and daycare centers. So who are the enthusiastic societies who have done their bit to visit these homes? And from Gujarat, Ahmedabad, Vadodara, Rajkot, Bharuch, and Surat, they have done a fantastic job. Raipur and Bhagalpur, Madurai, Chennai, and Bengaluru, Calicut, they have done the home visits, old age home visits. Jaipur, Udaipur, Gurugram, Faridabad, Agra, Patiala, Jalandhar also have done, and enthusiastically even on New Year and Christmas and on somebody's birthday, they have gone and celebrated along with these people in the homes. Then Bhopal, Lucknow, Gorakhpur, Patna, Bengal, and Hyderabad, all of us have gone to the homes and celebrated some festival or just gone to give awareness talks. And in fact, we have gone and gave them physiotherapy activities and made them do exercises. And some of them have come out with their talents of singing and poetry and so on. I think we have really enjoyed. That gives us satisfaction of doing something which we were not happening that way. So on behalf of all the members of the Society of IMS, I would like to share that our visit to homes was an eye-opener and heartening to see the women and men who have raised their children to give them the best education, better and comfortable life. But imagine they are left to survive on their own in this condition where they needed their support. Thank you so much for giving me this opportunity.
Thank you. Thank you, madam, for such a wonderful talk on IMS 70+. And I think it is one of the most important initiatives which have been taken up by Indian Menopause Society. And I feel every individual society should be doing this, not only visiting old age homes, but I think people who are elderly and staying at home, they also need to be looked into and attended to. So It is not only the medical facility, the physical and the mental issues that need to be dealt with. But I think other things also need to be looked into. Because I was reading an article a few days back, and it says the longest lived individuals are those who have a sense of purpose in life.
Yes.
So we have to engage them in activities which give them a sense of purpose and abolish the loneliness that they are having, even if they're staying with children. Some people are still lonely if they're staying at home. So engaging in activities, doing some creative work, volunteering, joining some clubs, all that has to be looked after. I feel that. So a very wonderful talk, ma'am, and about the policies that you have explained. I was not aware of that.
Yes.
I hope the government is looking into it. And as part of an Indian menopause society, we all have to chip in and do our bits. Thank you so much.
Thank you, Dr. Kavita and Dr. Jamuna and the all vision of Dr. Shobhana. Ma tujhe salam.
Really heartening to see 25 societies have gone to old age homes.
Yeah.
Out of 44. It's really,
Wonderful.
I think it's really good, no? Yeah,
So I
hope
think we
it
should
continues
continue.
forever and ever and ever.
Yes.
So moving forward, I will invite Dr. Sharma is Professor and Head of Skyni, Srivastava Naik Government Medical College, Yavatmal, and she has sent her apology and best wishes. So I will invite Dr. Reena Srivastava. She is ex-professor in HOD, OBGYN Gorakhpur. And we all know she is a stalwart in the menopause field. She was the ex-president Gorakhpur Menopause Society. She was past president of UP chapter of OBGYN and the OBGYN Society Gorakhpur. So Madam is going to speak on another untouched topic, which we should know, that the GI effect in the menopause women. Over to you, Reena ji.
Thank you, Ragini, for nice words, and thank you, your team, and IMS for this opportunity. So I would be talking on gastrointestinal tract changes in elderly population. We are well known that life expectancy has increased, elderly population is increasing, and in 2050 we are going to have 32 billion female above 80. So we have to be well versed with other problems also, which may give rise to low abdominal pain, and she may come to us. GI changes in elderly are common. Some are physiological, some are pathological, and some GI diseases, they are more prevalent in this age group. Changes of aging is loss of physiological integrity, and this leads to impaired function and so many diseases also, like cancer, diabetes, serious disorders, neurodegenerative disorders. This has been talked about. The aging affects all functions of the GI system, be it motility, enzyme, hormone secretion, digestion, absorption, even medication absorption. No GI disease that is very specific and limited to advanced stage. Some illness are more prevalent in this age group, and these may require a different management. Starting from oral cavity, the most common complaints come from oral cavity in the form of oral sensorial complaints, especially dry mouth or xerostomia, and 50% of elderly, they report at least one of oral sensorial complaints, be it xerostomia, be it taste disturbance, be it burning mouth syndrome, and it is speculated that it is because of decrease in salivary secretion and decrease in the quality of saliva. Xerostomia is one of the most common oral sensorial complaints associated with age-related alteration in saliva, I've already said, and so many times it is precipitated by tricyclic antidepressants and Parkinson medication. And when caused by medication, usually it is reversible. It can be as a part of other syndromes and diseases like Sjogren's, and salivary supplements can be used for it. And dysgeusia or ageusia, that is change in taste or absent taste. And so many medications, they precipitate it, like lithium salts, metronidazole, and commonly employed salts like levodopa, glipizide, captopril, clarithromycin. Then it can be a part of malnourished elderly leading to zinc deficiency. And maybe it is a part of Bell's palsy also. Oropharyngeal dysphagia. You must have seen patients like my own mother. She's not able to swallow a capsule or a big tablet. There is a sensation of difficulty in chewing food. There is difficulty in initiation of swallowing. And the cause is speculated that there might be changes that affect the complex neuromuscular mechanism that coordinates with the tongue movement, with the pharynx and the esophageal sphincter. And this coordination, when it gets lost by aging, there might be oropharyngeal dysphagia. The other causes could be stroke, multiple sclerosis, myasthenia, dementia, Parkinson's, muscular dystrophy. And the symptoms could be cough with swallowing. This is the most common symptom, and the food sticking in the throat. There might be nasal regurgitation also, and all this may increase the risk of aspiration. So there could be malnutrition, there could be aspiration pneumonia, there could be dehydration, and the incidence is around 13% above 65 years. Coming to esophagus, the presbyphagia is physiological change with age. There is increased risk of dysphagia and aspiration. I've already talked about it. There is a delayed esophageal emptying in healthy elderlies also. But the studies on esophageal motility have shown conflicting results. And might be the enteric neurons more vulnerable to age-related changes than other parts of the enteric system, as that in esophagus. The presentations could be esophageal dysphagia, odynophagia, GERD, Barrett's columnar lined esophagus, and medication-induced esophagitis. Esophageal dysphagia, we can just cannot say that it is because of aging. We have to rule out other causes. It could be mechanical, maybe because of a tumor, maybe neuromuscular cause, maybe inflammatory, and maybe infectious causes like candidiasis. When all have ruled out, then we can say it is because of aging. Then odynophagia, most common cause is infection, and elderlies have higher threshold for pain sensation. So this leads to a delayed presentation of odynophagia. GERD, high prevalence among elderly, 23%, and atypical presentation of odynophagia and dysphagia. Normally it presents like a heartburn, but in elderly it may present like odynophagia and dysphagia. When prescribing PPI, we should think of the side effects also, because it would continue for lifelong, and lifelong PPI, if given, that may cause many problems like interstitial nephritis, may cause osteoporosis, and so many other problems also. So if it is very much problematic, then laparoscopic anti-reflux surgery is safe and effective in elderly. Barrett's columnar lined epithelium, if it is present in elderly, then the problem of high-grade dysplasia and adenocarcinoma development is very much more. So it has to be taken seriously. Pale esophagitis is again more prevalent in elderly, and if the patient is having a cardiomegaly, again it will be more prevalent. Female gender and presence of diabetes are independent risk factors. It most commonly presents as chest pain, and when endoscopy is done, 80% of them are found to be having ulcers. Switching on to stomach, there is altered gastric microbiota, we all know. There's decreased blood flow, there's reduced mucosal protective mechanism. So there's a compromise in prepare and repair mechanisms, and these changes make older people susceptible to several diseases. Mortalities were not reduced in healthy elderly, as some studies have said. Then there is increased medication-related side effect. There is decrease in postprandial gastric emptying time and contractile force, according to some studies. And this reduction is more pronounced with Parkinson's and diabetes. Chronic atrophic esophagitis, gastritis might be there, and mostly it is seen in elderly with the 15.6% prevalence. Probably the cause is H. pylori. And this may cause SIBO, that is small intestinal bacterial overgrowth and malabsorption. Changes in human gastric microbiota is associated with increased risk for gastric cancer. And again, it can be associated with osteoporosis because of low absorption of calcium, and it may be associated with autoimmune thyroid and autoimmune ITP also. H. pylori infection incidence is high in elderly, and it is type 1 cancerogen associated with gastric adenocarcinoma. It has to be taken seriously and treated properly. Peptic ulcer disease, why? Because there is a decreased blood flow in GI, decreased secretion of bicarbonate, decreased mucin, decreased prostaglandins, and H. pylori infection. Associated changes in microbiomes cause hypochlorhydria. All this makes vulnerable for peptic ulcer disease, common in elderlies, and precipitated by NSAIDs and aspirin. That is the main risk, but anticoagulants, SSRIs, and oral steroids, they have to be taken care of because these may also cause it. The clinical manifestation is very atypical because normally it presents as typical epigastric pain, but here the manifestation may be atypical, not very severe pain, not typical epigastric pain, and even perforation also that lacks typical clinical symptoms of chemical peritonitis. Coming to small intestine, there is hormonal secretion and absorptive function is not different. There are minimal changes in small bowel motility and reduced mucosal immunity. The prevalent problems could be celiac disease, mesenteric ischemia, small bowel bleeding, and SIBO. Celiac disease, it normally doesn't present typically, and that's why there's a diagnostic delay. CD-related neurological manifestations such as patient might present with dementia, celiac ataxia, neuropathy, and they are difficult to diagnose and frequently they are misdiagnosed. 80% of the elderly with celiac disease, they will present as iron deficiency anemia, and they will be present with calcium and vitamin D deficiency. Mesenteric ischemia is not embolic in this elderly population, it is atherosclerotic, and chronic mesenteric ischemia will present as postprandial angina. And typically it should present like a severe abdominal pain. Even acute mesenteric ischemia will not present as severe abdominal pain, which is out of proportion of physical examination, but it would present with the confusion, tachypnea, vomiting, diarrhea. So the presentations in elderly people with all these things are delayed because of their atypical presentation. Small bowel bleeding, the most common etiology is angiodysplasia and small bowel ulcers. And they may be precipitated by NSAIDs, respond favorably to endoscopic treatment. Then small intestinal bacterial overgrowth, that is SIBO, very common in elderly and is associated with secondary nutritional deficiency due to malabsorption. Higher prevalence in elderly mainly due to achlorhydria and small bowel dysmotility. The clinical signs are usually very vague and subtle. They may just present as abdominal discomfort and bloating, which most of the elderly population is complaining of. Coming to large intestine, there is decreased ability of enteric smooth muscles to contract or relax, and there is reduction in neurotransmitters also. There is a decreased colon transit time and change in microbiota. Normally, the normal microbiome is formed with firmicutes and bacteroids, and they are in a balance. But if this balance is lost, then there is dendritic cells within lamina propria which get activated, and they secretes interleukin 6 and 17. There is decrease in mucus secretion, there is entry of pathogens, and there is inflammatory response. The most common presentation with large intestine is constipation, affects 50% of the elderly nursing home residents, caused by decreased mobility, cognitive impairment, comorbidities, polypharmacy also. And it has to be distinguished from IBS by the lack of abdominal pain and discomfort, and stool impaction is a significant complication. Diverticular disease becomes more common again in elderly, and the pathophysiology is linked to age-related changes of intestinal microbiome and connective tissue of the colonic wall. The prevalence increases with age. Irritable bowel syndrome, prevalence similar across all ages. Elderly are more likely to have an organic GI disease. So whenever this type of a problem is there, we should not take it granted as irritable bowel. It has to be thoroughly worked. And when we get nothing else, no other problem, then we can label it as irritable bowel syndrome. Rectal bleeding is common in these cases. Then Clostridium difficile colitis, elderly are particularly vulnerable, and hospitalization, healthcare acquisition, and the recurrence of CDC is significantly higher in those above 65 years. What happens that It may be precipitated by some antibiotics. There's formation of pseudomembranes. There's diarrhea, which is not responding to treatment. Vancomycin may help. And even the fecal transplant will not help much in the elderly population. Inflammatory bowel disease. 15% of newly diagnosed patients are above 65 years. And maybe because of reduced immunity and changes in the intestinal microbiota, this predisposes to the development of inflammatory bowel disease. Rectal bleeding is more common than diarrhea, weight loss, and abdominal pain. And the disease is less aggressive and progresses very slowly. A word about menopause and the microbiome. In the elderly population, nowadays what happens, what is the term used is microbiota instead of microflora. It is not plant kingdom, now it is a separate kingdom. And microbiome is an ecosystem within a human body consisting of varieties of organisms, bacteria mainly, viruses, fungi, bacteroids, and this occupies different parts of the body and contributes to the physiological function of that part. Gut microbiome accounts for 29% of the entire microbiome, and the 4 phylum they are commonly placed, that is bacteroids, firmicutes, acino, and proteobacteria. First 2 are more important and they should form a balance with each other. They are the function is related to the production of vitamins, amino acid synthesis, bile acid transformation. The performs essentially structural, metabolic, protective functions that benefit the body homeostasis and builds mucus layer. Changes in microbiome depend on various factors, and age is one of them. With increasing age, the microbiome definitely gets disturbed. And estrogen also is a very important factor. The estrogen metabolism is carried out by the gut microbiome also. Estrogen and phytoestrogens with bile acid in gut are deconjugated by beta-glucuronidase secretion by gut microbiome. And this metabolized estrogen and phytoestrogen, they go through the bloodstream and act on the various estrogen receptors. A reduction in gut microbiome leads to a decrease in circulating estrogen. Then sex hormone levels exert specific influence on the composition of the, so that vice versa, they both depend on each other. If the sex hormones are less, the microbiome is disturbed. If microbiome is disturbed, the sex hormones are disturbed. And also the removal of gut microbiota increase the testosterone concentration in female mice, but decrease in male mice. So a novel concept of microgenderome has emerged, potential bidirectional interaction role between sex hormone and gut microbiome. Estrobolome is defined as the gen repertoire of the microbiota of the gut capable of metabolizing estrogen. With menopause, the gut microbiome loses its alpha diversity and beta diversity. Hence, the estrobolome changes to what is now known as androgenic. So the lady becomes more prone to obesity and metabolic syndrome. So what management? There are various challenges in the management of these GI problems in elderly population, because which changes GI function is a part of normal aging and which is pathological is a bit confusing. And management of GI disease in elderly, including diagnostic algorithm as well as therapeutic intervention, is complicated by comorbidities and polypharmacy also. So elderly commonly have a typical atypical presentation with more subtle symptoms of disease, and the side effects of polypharmacy complicate the clinical picture. Elderly patients represent a specific population and unique needs in regard to diagnostic and therapeutic approaches. So what we can do? Basically, the message is that with the gut problems in every elderly woman, we should not take it granted that it is because of aging, because there might be some important, very organic, problematic things inside. It has to be referred to a GI clinician, let him examine, let him say that there's nothing, only then we can label it as a aging process. And what we can do in our day-to-day practice, it has all been talked about. Let thy food be thy medicine. Diet I'm not going to talk about. If there is dysphagia or thorough chewing, gentle, good dental health should be there, proper fitting dentures, eating slowly, sitting upright while eating. Then if there is functional dysphagia and GERD, find your own trigger food, avoid common trigger food, that is fatty food, spices, alcohol, caffeine, maintain healthy body weight, quitting cigarette and alcohol, avoid lying down right after eating, elevate head end of the bed by 6 inches. Exercise, I'm not going to talk much. It has already been taken since morning. Sleep, of course, 7 to 8 hours. De-stress, this I would like to stress upon because stress contributes worsening digestive symptoms. And regular exercises, taking time for yourself, good belly laugh, becoming a better breather, monitoring negative thoughts, spending time with the friends. This is going to give a positive effect on the gastrointestinal tract. And I think GI surgeon would be a better person to label and diagnose a GI problem. Aging is giving rise to so many problems, and with better living lifestyle, diet, exercise, walking, all this may bring down the problems to some extent. That is the message. Thank you all for patient listening.
Thank you, Reena ji. Thank you so much. Our eating is an important thing, what to eat, what not to eat at this age. And how to maintain yourself is very important. So that's why I thought we should touch these topics also, because they are the part of the aging. As Dr. Alka does the oral and hearing and eye loss, and to you the GI, but you have done really a very good job. So, moving forward, I will invite Dr. Anjana. And Dr. Anjana Chauhan is basically, she's a gynae oncosurgeon, and she's professor OBGY department, Swaminarayan Institute, Kalol, Gujarat, and founder director of the Anurika Empowerment Foundation. And she was a president Ahmedabad Menopause Society, member of many Best Paper Award. Over to you, Anjana ji, to introduce Dr. Meenakshi Ahuja.
Thank you, Dr. Ragini. It's a wonderful, what we can say, webinar from since morning. I am listening, and it's wonderful. All the topics are very nicely covered, and especially you have gone into details of each and everything, ma'am. That's how to live after 40, exercise, and the titles are given very wonderful. And my speaker is Miss Dr. Meenakshi Ahuja, and a wonderful title, Beating Heart. It's like I'm listening to some music. And to introduce her, she's a director, 40s Love Feminine. She is an obstetrician gynecology, cosmetic gynecology. She's a president of Menopause Society Delhi. She's the academic secretary, Delhi Gynec Forum. She also has lots of, accolades on her cap, and is a past president of Delhi Obstetric Gynec Society. Madam, I invite you for the talk, The Beating Heart. We just want to hear from you.
And Meenakshi is a very good cook also, and her blogs and her social media is wonderful.
I'll start my talk, and I've been given a very interesting talk, which is that about the heart. And as we've been seeing in all this while, people have been talking that this topic is close to my heart, this topic is close to my heart, or, this really touches me to my heart. So it means that heart is actually probably the most important organ in our body, and probably even more important than our brain, because I think more of us think and work from our heart than from our brain. And that is why it becomes even more important to talk about matters of the heart. Anyway, menopause happens to every woman, but we all know that it does affect the heart. And that is why it becomes very important that we discuss it. Menopause is a stage in every woman's life when the ovaries are going to stop functioning, and the estrogen is going to affect every organ, more so the heart. The estrogen is important. So estrogen is important because it helps to protect a number of a different part of the body. I thought actually everyone's been showing slides in the morning. So let me just make this a talk that it's more of a conversation, because it's more from the heart rather than from the brain, right? So it helps to protect a number of different parts of the body, including the heart, the blood vessels, the bones, the brain, the skin, the vagina, so that they can all be affected by the low levels of estrogen. The symptoms of menopause can last anything from 3 months to more than 10 years, like the palpitations and the PMS that we have. And the effects are seen for more than half of our adult life. Estrogen protects the arteries of the heart, and in a number of ways, including the reducing of the building up of the fatty plaque. This means that after menopause, you are definitely at an increased risk of heart and circulatory disease. Low estrogen can increase and will increase the cholesterol levels, which will obviously increase our risk of developing heart and circulatory disorders after menopause. Menopause can cause palpitations, that is the feeling of the heartbeat being faster than usual because of the changing hormonal levels. This is possible that it is going to happen in hot flashes or in anxiety or other symptoms associated with menopause. And that's why we have to understand that how the heart is being affected by menopause. This is the first part of the discussion that I'm doing today. So how does early menopause increase the heart risk? So with premature menopause, when we know that 1 in 100 women experience early menopause before the age of 40, this also puts them at a particularly high risk of premature heart disease and circulatory disease, as well as, of course, osteoporosis and other problems like GSM symptoms of menopause. And that is why if a woman is less than 45 or when she experiences menopause, she must check her cardiac health and give a much more importance to it than normal, especially if there's a family history as far as this is concerned. Also, because we know that menopause is associated with thyroid disease, there could be viral infections and eating disorders which are associated, or women have had surgeries or surgically induced menopause. That, of course, is also going to affect the estrogen levels directly as well as indirectly and put the woman at more cardiovascular risk. So what do we do? Obviously, we all know that HRT is not the heart disease is not an indication for HRT. But if we are giving HRT, there is definitely a lot of cardioprotection. So for whatever other symptoms that we have, like vasomotor symptoms, or where we are using oral HRT, it is definitely going to give cardioprotection. Obviously, the local medications that we are using for GSM are not going to do it, but probably if we are giving it in prevention of osteoporosis, it is also going to help the cardiac health. Now, this was how menopause can affect the cardiac health. And yes, that there is the role of MHT in taking care of cardiac health. But what can we do as women with our patients and with ourselves as menopause comes in and take care of our heart? So this is very basic, and that's the reason why I didn't put in slides here. That is the diet and the exercise and the lifestyle changes. So we are going to cover all three of them. There is, of course, the importance of a healthy, balanced diet, which probably all of us have been reading about from class 2. The pyramid which is there, where we are supposed to have more fruits and vegetables in our diet, more protein, lesser of carbohydrates, or at least a balance of that, and less fats in our diet. As far as menopause is concerned, probably our calories need to be reduced once we reach menopause because the utilization is much less. That's number one. We need to cut off on the, or at least lessen the amount of meats in our diet, even though we are looking for protein. And that's why plant-based proteins becomes a very good idea in these cases. Cutting off a little bit of dairy, even though it means that we are getting proteins from the milk, is a good idea because dairy is also probably more inflammogenic. And now more and more fads are coming in, and research is showing that probably we don't need too much of dairy at least, although that good balanced amount of yogurt that we have in our Indian diets is definitely beneficial. Adding in omega-3 or cardioprotective foods like nuts and seeds becomes very important. Take care that there's adequate amount of fruits and vegetables and fiber in your diet, as well as the colored foods. So now that balance of color and having a rainbow diet and a Mediterranean diet, especially in menopause, is coming in, not only for your overall health, but also for your cardio protection. And that is why that these things are not only important, they're imperative, and these changes need to be taken care of in our diet as well as our patient's diet. Coming to things that we definitely need to avoid, women who are smokers, the cardiac health is going to be affected directly by smoking, and that's why it needs to be cut off completely. Alcohol, of course, needs to be lessened because even the capacity becomes less and it is going to affect the cardiac health. But they say that a measured amount of alcohol is okay, but only in moderation and not too much of alcohol. Coming to exercise, which is the other important part here. So exercise needs to be there. You don't need to be doing intensive workouts. Dr. Sudhaa has already talked about exercises which need to be done for preventing osteoporosis and sarcopenia. But even for your cardiac health, your regular exercise becomes very important. So 30 to 40 minutes of exercise at least 3 times a week with regular walking every single day. So probably a moderate amount of exercise that is, and trying to make changes in your lifestyle, like say walking to the market or going up and down the stairs, or even things like fixing up your bed and folding your laundry and linen is an exercise. So being active, alert, and putting in time for exercise every day is going to help. Exercise also helps because it calms your mind as well as your heart. So things like yoga have been seen that they have a very, very important role today. So calming of the heart becomes very important. And that is why a regular walk, a swim, or yoga has been seen to have very good benefits in keeping your heart rate very regular. Just a word of caution that if you've not been exercising regularly, because the heart is not what it is at 30, don't start. There are cases where people are, think that they're very fit and they're intensively gymming or intensively going for marathons, and then their heart suddenly gives up. And that's why please do exercise regularly in moderation, and again, like your diet, in a balanced way. Suddenly pushing yourself over limits is also not good for the heart. And that's one word of caution that I would always advise, if especially we are talking about your cardiac health as far as menopause is concerned. I think once we've talked about, I'm not going to be delving into treatment of heart disease in menopause or on the medications which are going to be used. What I wanted to talk more about was in prevention, where we were going to talk about basics like diet, exercise, lifestyle changes. And then probably something which is the heading of our symposium today, that is happiness. So happiness is very, very important to keep your heart happy and healthy. And that is why look for things which give you happiness. Don't hold on to, little things which people may say, इसने ऐसा क्यों कहा, मेरे साथ ऐसे क्यों हुआ, तुमने तो बोला था तुम फोन करोगी, फिर फोन नहीं किया, and all. Learn to let go. What doesn't matter in 5 years, don't waste more than 5 minutes on it. Because, like I said, your heart is probably the most precious organ in your body. And that is why it's very important that you look for sources of happiness, and more importantly, let go of things which don't make you happy. There's a mantra that I use in my life. Dr. Ragini was, when she was introducing me, she was talking about me as a person and my Instagram account and all that. So frankly, the reason why I do it, there are a lot of doctors I've seen who started having their Instagram pages and all to promote themselves. That's great. But the point is that when I write or I share something on Instagram or Facebook or whatever, it is probably because it gives me joy. It's just that. It just gives me happiness. It gives me an opportunity to share what made me happy. Everyone has happiness. People say that social media is a fake and all that, and people like to show that their lives are happier. But I personally feel that what gives you joy, if you share it, it will multiply and it's going to make you happier. And in a way, it is healing for your heart as well as your soul. And that is the reason why I do it. It's not to show off that, okay, I went to 20 countries or I did this or I ate this or did that. No, it's just that it's a basic thing that it gives me joy. And when people who are like-minded connect with me on that and talk about it, that gives them, gives me even more happiness that yes, I'm sharing an experience and I'm happy to see the experiences that other people have. So what I'm trying to say is that whatever you're do it out of passion. So passion is the other thing. Again, passion is never with your head. It is with your heart. So if you're passionate about something, it means that your blood is circulating well in your heart and you're doing something that you're happy about, you're passionate about. And that's why you will do it well also, whether it's work, whether it's a hobby that you can have in your life, whether it's, whatever you can follow in whichever way. The important thing here is also that everyone can't do everything. That also, we have to understand that. And a very basic mantra, like I said in life, is 100% acceptance and 0% expectance. Keeps your heart calm, keeps you happy, and keeps you going forward. So the only thing you do is that whatever anyone says, accept it, that probably that's what they feel is right, even though it may be conflicting with you. And similarly, having that expectance, isne mere liye ye nahi kiya, wo nahi kiya, isne ye nahi kiya. Keep it out of your life. Your heart will be a better place for you. And that is something that you must protect, because that is what is going to be with you till your last beating moment. So it is very important that you inculcate a hobby, spend whatever time you can. Don't think mere paas to time nahi hai. No, it may be half an hour, 1 hour, but learn to have that me time in whichever way, and learn to believe also. Like I always say that my work is my passion. It makes me very happy. I really don't know whether there was a time when I used to, feel very bad that I was busy at night and missing out on stuff with my family and children. But no, I made my mind believe it, that it makes me happy. And I don't think I've ever doubted that my work keeps me happy. And that's why your heart becomes happy, because you're passionate about your work. Or we discussed this, that there has to be passion, there has to be some excitement in your life, and there has to be a calming effect in my life. So calming was with your yoga, exercise, swimming, meditation. And excitement is by following your passions, following your dreams, because at the end of the day, I like the youngsters say, YOLO, you only live once. So when you are living, live from your heart and learn to do anything that you can to the best of your abilities in whichever situation you're put to, so that it doesn't put your heart to, task or otherwise. So I think that's the mantra of having a happy heart, and like, which was part of our topic today and part of the symposium. And here, right at the end, I would really like to make one very small confession, that actually speaking, I had got a message about this symposium on the 8th of December. And after that, I was also just tied up with a lot of things and all, which is definitely to my, what should I say, discredit. But I actually didn't see. I think that's the disadvantage of social media also sometimes, that, you can miss WhatsApp messages. And I managed to just miss some messages and some calls. And I actually looked at this symposium also today, and I didn't scroll to the last part, which said that, yes, I had a talk to present. And now at that time, I could have had anxiety. And probably at 4 o'clock, Deepika rang me up and said, your topic is next. And I was in the car, and that's why I wasn't even available. I reached home and my laptop wasn't even charged. But I said that, it's something which the topic is something, like I said, very close to my heart. And we've been learning academics and medicine from morning till evening every single day on webinars. So let me just share this in a different way. You've given me the opportunity of 10 minutes. Let me utilize it. So I guess that's, with the calming effect that we have on our heart, this was something which was the excitement in my day today, that I decided that let me just speak extempore and just, put a little bit of academics, but probably just go on this way, that how our heart matters and how we need to take care of it. Thank you so much.
Thank you, Meenakshi. Thank you so much. Our all heart is beating now in a new way. I will invite Dr. Surita Kareem from Gorakhpur. She's the president of the Gurgaon Menopause Society. She's also a gynecological surgeon. And I have met her recently in the East Zone Menopause Society. Over to you, madam, to introduce the next speaker, Dr. Sudhaa Sharma from Jammu.
Thank you so much, Dr. Ragini, for holding this webinar. It's been wonderful from the morning you've been at it. And I think you have covered a whole range of topics, and especially some of them are so interesting that my Sunday got all used by the Indian Menopause Society this time. Anyway, it's my proud privilege to now introduce a former professor from the PG department of Jammu and Kashmir, Dr. Sudhaa Sharma. Ma'am, welcome to the webinar. And we can all, I think, see the screen. She's been the Secretary General IMS and an honorary professor of IMA. She is the Managing Committee member of PCOS Society of India. And she has been the president of Jammu Obs and Gynae Society from 2018 to 20. And she is the founder president of Jammu Menopause Society. I think that's commendable, really good. And editor-in-chief of the JMH, the Journal of Midlife Health, and member of the editorial board, Journal of SAFOG, and editor-in-general JK Science, Journal of Medical Education and Research. And she is the member, National Advisory Board and Journal Committee, Journal of OBGYN 2006-11, and faculty member of Menopause and Osteoporosis IMS. Besides this, she has 70 books and publications and book chapters, obviously a very renowned academic. So I would welcome Dr. Sudhaa Sharma. Kindly, ma'am, deliver a talk and enlighten us.
Thank you so much, madam, for your kind words and nice introduction. So I'll share my screen. Thank you, Dr. Ragini, for this conference, wonderful, and for giving me this opportunity. It's bone and joint. Let's move. I would say, Dr. Ragini, why move? Let's dance. So it's a saying, don't break someone's heart. They have only one. If you want to break their bones. They have 206 of them.
Great.
So friends,
Great.
I didn't know. Believe me, I didn't know that infants have only, they have about 300 bones, while we adults have only 206, because some of the bones, they fuse to form bigger bones in the process of development, thus reducing the number to 206. They are dynamic structures that are undergoing constant change and remodeling. They produce RBCs, WBCs, store minerals, and thus provide structure, support, and mobility for the body. You know, the bones in them have a honeycomb-like matrix, which helps to give them rigidity. So bone mineral is made up of small crystals, which contain carbonate, magnesium, sodium, and potassium. So this mineralization requires calcium phosphate, alkaline phosphate, and vitamin D. Now, when we measure amount of minerals, which is contained in a certain volume of bone, that forms the bone mineral density. So bone mass and bone density, they are the measurements that indicate bone quality. Now we have phases in the skeletal life cycle that starts right from the birth, because BMD starts to increase from the birth. It peaks around 14 years in female and around 16 years in male. Point to be noted, males have a longer duration of bone mass development. So bone mass would be higher in them at any given point of time. And peak bone mass is reached by 25 to 35 years. And there are many factors which help to, attain good peak bone mass. Genetic, very important factor, nutrition, in utero, outside, physical activity, the kind of hormones you have in your body. And after that comes the remodeling phase, a process in which old bone is resorbed and new bone gets deposited. After that, there is a gradual decrease in the bone mineral density, 0.5% as we age, which is accelerated following menopause. So with advancing age, what happens? New bone formation is gradually outspaced by the bone loss. So the total skeletal mass slowly declines, and that causes osteopenia and osteoporosis. So coming to osteoporosis, which is always underdiagnosed and undertreated. You know why? Because it's a silent disease. It manifests only when you have a fracture, but it's a global problem. So it's a metabolic disease where you have deterioration of the bone tissue, low mineral density, increase in fracture risk. And, there are serious consequences why we are discussing here, because, out of 100 females who get, hip fracture, 20%, die within 1 year of that fracture, and 50% do not recover fully. So that's the morbidity and mortality of this disease. Now look at this projected global distribution of fractures. In 2050, we Asians, we are going to occupy more than 50% of the whole, world population as far as the fractures they go. And look at 1990, this thing, where we were at nearly 31%. Now, why fractures are common at certain points? We need to look at that, because skeleton is composed of two types of bone. Cortical, that is the compact, they are 80%, which predominates in skull and shaft of long bones. And then we have trabecular or cancellous bone, which is only 20%. That is in the vertebrae and distal ends of the long bone. But this 20% of the bone has a honeycomb-like appearance, which has surface area which is equal to the 80% of cortical bone. And at this point of time, the bone remodeling is very fast, bone turnover is very fast. That's why the fractures occur at spine, distal radius, and hip, which have more of the trabecular bone. Now, we need to know what are the risk factors of, decreased bone mass and osteoporosis. They start right in utero, because it has been seen that there is a direct relationship between birth weight, weight in infancy, and adult bone mass. Because small for dates babies have been seen to have higher rate of bone loss and increased risk of fractures in their later life. Genetic, very strong factor. Hip fracture, if you have hip fracture in one of the parents, 50% chances of having hip fracture in you. Advancing age, gender, of course, we females are more prone. Previous fragility fracture or, minimal trauma fracture. Menopause, of course, is a high risk factor. And if you have premature menopause, all the more. Then low body weight, small built females, and prolonged amenorrhea. But, unfortunately, all of these factors, most of them, they are unmodifiable. Then we have certain modifiable risk factors. If we, take care of them, we would certainly be having strong bones, like cigarette smoking, tobacco use, excessive alcohol, deficiency calcium, vitamin D, lack of exercise, and lot of caffeine and lot of animal proteins, which are known to be the bone robbers. Now, how do we diagnose it? Measurement of bone mineral density is used as a marker for osteoporosis, and the relationship between low BMD and fracture is same as the relationship between high cholesterol and myocardial infarction. And WHO has given osteoporosis definition, which is based on T-score. And what is this T-score? It is a comparison between the solidness of the bones with average young healthy population and is measured in standard deviation. So if your T-score is less than -1 standard deviation than the young population, it is normal. If it is between -1 and -2.5, it is osteopenia. Less than 2.5, osteoporosis. And if you have a fracture with it, it is severe osteoporosis. Now, we cannot subject all the females to bone mineral density testing, since DEXA is the gold standard and it is expensive, not available everywhere. So Indian Menopause Society has given certain guidelines for the females who are to be subjected for screening of osteoporosis for diagnosis. All postmenopausal females more than 5 years of menopause, less than 5 years with risk factor, in menopause transition with secondary causes. If you have on X-ray the evidence of osteopenia or vertebral compression fracture, women with fragility fractures, and ideally before initiating any pharmacotherapy for osteoporosis. Again, you have WHO has given this online model, which is online tool for screening of osteoporosis, and that is FREX. You have to feed the certain parameters in this, and then you can calculate 10-year probability of fracture. ASTA, again, WHO has developed the ASTA score, which is a risk assessment tool, which is based simply on age and body weight to identify the women at risk for osteoporosis. This is offline model. You can, keep it on the table. On one side, you can fill your weight on the other side, the age, and you will fall in one out of these three, thus knowing which area you are fitting in, low, medium, or high risk for osteoporosis. Now, once we are known that these females are osteoporotic or osteopenia, what should be the approaches to the prevention of bone health? Since there is 10%, with 10% increase in bone mass, fracture risk reduction is by 50%. So we have to, give importance to lifestyle modifications, and they start right from the intrauterine life. Optimization of maternal nutrition and intrauterine growth would be the first line of preventive strategies. So well-balanced diet, a lot of calcium, vitamin D, and other nutrients should be given to all the pregnant females. And I think we all know what are the recommended dosages of calcium during pregnancy, menopause, and post-menopause. And these are the charts, dietary products in which, we can see how much calcium per gram, so we can use them accordingly. The second lifestyle, which is very important, is exercise and bone health. All types of physical activity can contribute to bone health, but you have to keep this thing in mind that the effect of physical activity would persist as long as the activity is there. You stop the activity, the effect will be reduced. And all the different type of exercises that help in building the bone mass are weight bearing, strong impact exercises. So these are the exercises which should not be done by all those who have low bone mass. Maybe Dr. Maninder can do all these things, but not this is not the exercises for all of us. We can do weight bearing, low impact exercises, and most important one is the walking. You can walk on treadmill or you can walk outside. You have then resistance training, weight or strength training exercises, activities where you move your body, weight or some resistance against gravity. Then you have non-impact exercises which help to improve balance, posture, increase the muscle strength. These are the weight bearing, resistance, and balance training exercises. Then you have non-weight bearing and non-impact that can be a part of the exercise program, but they do not build the bones. And of course, all of us should know what are the fall preventive measures. Now, what are the other aspects of bone healthy lifestyles? Smoking. Smokers lose bone more rapidly, and in them the fractures heal very slowly. Alcohol, moderate intake may have no effect, but more than 3 drinks detrimental. Medication, once you are prescribing, and maintaining healthy body weight is also very important. Now, what should be the management plan? We have to evaluate the high risk category by excluding secondary causes, and universal counseling about lifestyle measures has to be instituted to everyone. And if they need the treatment, selection of appropriate treatment has to be done. Now, when to treat? If she has osteopenia with no risk factors, just instill lifestyle modifications. But with osteopenia, if there is one risk factor, you have to treat them with pharmacotherapy. And of course, osteoporosis needs to be treated. So not going into the details of therapies for osteoporosis, just touching them. We have two types of therapies, anti-resorptive and anabolic. Anti-resorptive are the ones which slow down the absorption and they have action on the osteoclast. They will help in, slow down the resorption of the bone. Whereas anabolic therapies, they stimulate the bone formation because they have their action on osteoblast. So among us, the anti-resorptive therapies, you have the bisphosphonates, we all know, denosumab, raloxifene, and strontium. And in the anabolic therapy, we have parathormone or teriparatide. So bisphosphonates, I will not go into the details. We have the alendronate, the risperidone, ibendronate, and zoledronic acid. So we have, per day therapy, we have per week therapy, per month therapy, after 3 months, and we have yearly therapy also as far as bisphosphonates are concerned, because they are highly, highly effective in vertebral as well as non-vertebral fractures. Then you have SERMs, selective estrogen receptor modulator, and the FDA approved is, which is FDA approved is, raloxifene, which is given in the dosage of 60 milligram per day with fewer side effects like hot flushes and leg cramps. So we cannot give this drug in, perimenopause and immediate postmenopausal females if they are having hot flushes, because they will increase them. Then calcitonin can be given in the form of subcutaneous injections and nasal sprays, and it has a possible analgesic effect in women who have painful vertebral fractures. But it has been withdrawn because it was seen that the risk of developing cancer was 2.4% higher in patients who used calcitonin nasal spray when it was compared with those who were taking placebo. Hormonal replacement therapy, we all know that we used to give it for the prevention as well as for the treatment of osteoporosis before Women Health Initiative study. But after WHI trial, it is no more the first line therapy for osteoporosis. Yes, of course, if we are giving it for some other indication, we will definitely have a benefit on our bones. Then strontium ranelate, the dosage is 2 gram oral suspension, but again, it has been withdrawn because of the increased incidence of cardiac events, thromboembolism, and liver inflammation. Then you have a parathyroid hormone, which is anabolic, increases the bone formation and BMD at all the sites. It is FDA approved, but only for 2 years. Dosage is 20 microgram per subcutaneous and is reserved for those cases who are severely, osteoporotic or who have had one fracture earlier. Then these are the drugs which I have already, touched. Then you have denosumab, which is a human monoclonal antibody that inhibits RANKL, and it is, given in the injection form. It inhibits the interaction of RANKL and acts to inhibit the bone resorption. 60 milligram dose by subcutaneous injection and every 6 months. And we have a lot of pharmaceutical companies who have denosumab, and very rare side effects is osteonecrosis of jaw and atypical fracture of femur. How long the treatment should be given? As per the NAMS guidelines, treatment needs to be long-term, because decision to discontinue the therapy would be based on the woman's risk of fracture, her response to treatment, and likelihood of diminishing beneficial effect from the agent used. And long-term careful monitoring is always required. So joints, I will not go into the details. We all know that they are the areas where two bones come together, not directly, but they are cushioned by the cartilage, synovial membrane, fluids around the joints. As we age, the joints become stiffer and less flexible. The cartilage may degenerate, they may rub together and wear away. So we can have, inflammatory and degenerative changes in our joints. Osteoarthritis is the disease that disproportionately affects the postmenopausal females. So age is the strongest factor, obesity, but menopause relation is not clear. There is a cartilage loss, pain, and radiographic changes. So as far as treatment, pharmacological and non-pharmacological modalities are available, but weight loss, physical and occupational therapy, they form a great role, and of course treatment as and when required. So this I want to share with you. Two of my loved ones, they suffered from osteoporotic hip fractures. One was my mother and one was my mother-in-law. So I got interested in the subject and learned few things once I was going through this subject, and I want to share this with the house, that I am the daughter of an osteoporotic mother, hence at risk of having osteoporosis. So I better take care of myself. I learned what is minimal trauma fracture. When you fall from a standing height and break your bones, like if I am 5'3", if I fall from a height of 5'3", can break my bones. This is minimal trauma fracture or fragility fracture. What is the commonest site of fracture? Because they have the trabecular bone.
Hello.
I also learned that men have more deep BMD than women. Their skull may be hard, but how about gray matter? That you people have to decide. Then, if you want to celebrate any event, don't go beyond 2 drinks. And this is something which I cannot forget. I should have given some pharmacotherapy to my mother after first fracture. I did not because I didn't know. And she suffered another fracture after 2 years and she was never the same. And I also learned what it means, socioeconomic burden and personal sufferings. So dear friends, healthy bones are very important for the healthy body. Don't forget, what you do to your bones today, they will have an impact on you when you grow old. So dear all, if you take good care of yourself, if you have, strong bones, if you have flexible joints, if you have a strong locomotor system, then you can also dance like this. Thank you very much.
Thank you so much. Dr. Sarita, any comment?
Thank you. Thank you. No, I'm very glad that this was the topic for where I had to chair, because the topic is very close to my heart. Like Dr. Sudhaa, even I lost my mother to a fracture. And she was on the bed for 3 months and she had a intratrochanteric hip fracture. So I'm so glad now we have the Society of Indian Menopause Society, which is, guiding us, and through us, maybe other colleagues and other juniors also, to take care of bones and bone health, which is obviously the underlying statement of her talk. And a very well presented and a very concise presentation. Thank you so much. And thank you, Dr. Ragini, for the opportunity.
Thank you so much. So moving forward, sir is sitting from quite time he is here. Sir is MD from the Government Medical College, Patiala, and he's at present is retired as a professor, Department of OBGYN, Patiala Medical College, and is looking for the Patiala IMS chapter. Welcome, sir.
Thanks,
and sir is, please introduce Dr. Natasha, our next speaker.
Yes. Thanks, Madam Ragini, and congratulations for your very, very good webinar. I introduce Dr. Natasha Vijendran. She is MBBS MD and dermatologist, hair transplant surgeon, aesthetic injector, laser specialist, deals in metabolic medicine and holistic dermatology. Consultant dermatologist at Dermasense, consultant dermatologist, Pratik Shah Hospital, Gurgaon, and he's the founder and head of Trico 360, and also available on Facebook and Instagram. I request Dr. Natasha Vijendran to start the talk.
Good evening, everyone. Today we're going to be talking about the skin changes that we see in menopause. And I had a lovely time listening to everyone speak about the bone changes, the GI changes, usually issues that we keep on missing out when we talk about menopause. So today we're going to talk about the skin changes. And we know that, during menopause, there are so many hormonal altercations that take place. And one of the main changes that occur in our body is a physiological, physical, and sexual change. So 85% of women do present with skin and hair changes. And the skin, as we know, is an endocrine organ and major target for a lot of hormones like estrogen and androgen and cortisol. So basically what happens, the skin changes are not due to an increased androgen level. It is because the estrogen levels that have fallen and the constant androgen levels which are present, they cause a lot of unwelcome changes that seem to have just settled overnight. The dermatoses that are associated with menopause, predominantly we categorize it into 3 parts: physiological changes, age-related changes, hormonal dependent changes, and hormone replacement therapy induced changes. So I'll be briefly taking you through all these skin changes and how to quickly treat them. Okay, coming to the physiological changes of the skin. Overall, during menopause, what we've already discussed, that the skin atrophies, it becomes friable, there's more bleeding tendencies. But along with that, what happens to our glands is that they are becoming atrophic, so your sweat production is reducing. On the other hand, because of the androgen stimulation, your apocrine glands become overactive and you might notice an increased sebum production. Along with that, the hair on the scalp reduces and the hair on the face and body increases. And our body weight also, there is constant fluctuation, giving you a more android body feces. When we look at the age-related changes that happen to the skin, predominantly the thickness of the skin reduces by about 1.13% every post-menopausal year. This is extremely important. And along with this, even our collagen content keeps reducing. So this can be due to either an extrinsic factor or an intrinsic factor. Extrinsic, as we know, ma'am already took a lovely lecture. So smoking, alcohol intake, sun exposure, exposure to a lot of harmful environmental factors cause premature aging of skin. When we look at the intrinsic factors, we know that telomeres play a very big in aging, and that is what a lot of illnesses, a lot of chronic drugs, diabetes mellitus, traumas and surgeries also accelerate your skin aging process. When we look at atrophy of the dermis, we want to see what basically happens and what happens to the skin. So first and foremost, what most women come with saying that their skin has become very dry and itchy. It's become fragile. So there's easy bruising that takes place of the skin. And of course, your skin is more prone to infections and trauma. Okay. We also know that collagen metabolism is very massively affected with menopause. It causes your skin to lose its suppleness. You see a lot of wrinkles, you see a lot of fine lines, and also sagging of skin takes place because of collagen loss. So this is a diagram where we say how a hyaluronic acid and collagen in our skin reduces over the age. And we see by the time of 40 to 60 is when it reduces rapidly. And what that causes is you see dull and dry looking skin. Your skin loses its structure and volume, and it also becomes very wrinkly. Looking at the androgen effect on the skin and hair mucosa, we know that androgen fibers are present in the skin, in your hair follicle and sebaceous glands. So what basically happens is there's an increase in acne. You must have had acne in your teenage years or during your pregnancy, and that's coming back now in menopause. A very, very common and distressing thing is your androgenic and female pattern alopecia and hirsutism, of course. Looking at the estrogen-dependent changes that we see in women, mainly we know that the estrogen receptors are abundant over the genital areas, face and lower limbs. And hence the skin in these areas are the most commonly affected. We see that estrogen directly affects your skin by reducing the skin thickness and opacity. It also, when estrogen reduces, it causes a lot of sagging in the skin, as it is the basis of your dermis. Along with that, different other things in your skin also reduce, like hyaluronic acid, sebum, and mucopolysaccharides. So this is a chart showing how estrogen reduces over the age and how it is affecting the skin. What are the first signs of aging that you will notice in your skin? It usually starts by the age of 30 and it increases over the years. So first and foremost, you'll see that your skin is becoming dry, itchiness is increasing. Along with skin atrophy, uneven pigmentation also comes up. Wrinkles around the eyes, the mouth, and your forehead lines and frown lines become more visible. And of course, there's a loss of skin tone. So either you become more paler in appearance or pigmentation issues become more intense. Along with that, I've already mentioned sagging of skin and more pores become visible. So to treat all of this, there are various mechanisms and various treatment options that are there. Threads, Botox and fillers, fractional lasers, and help very well in changing the texture, reversing the texture of your skin, and also addressing all the sagging and wrinkle formation. In this lovely patient, we've used threads and fillers to target her eye area and her oral area, and fractional lasers also were used to improve the texture of her overall skin. We have another beautiful patient here. So she was more concerned with the wrinkles which are become static with age. So we've used hyaluronic acid fillers here to fill in the loopholes that were present. However, with a very advanced age, it's very difficult, to give you results how you were back when you were 35. But this patient was very happy with how her skin looked more supple and the fine lines and wrinkles were less visible. Botox, again, is a wonderful treatment for wrinkles and, static wrinkles. As we see, it can be used in the forehead, it can be used around the eye, and it can also be used for your frown lines and angry lines. Fillers are also used in the genital area. So because of the atrophy, dryness, we can use fillers in these areas. The moisture content of the skin improves, thus reducing the itching and the dryness. And it also gives for a more plump and full looking labia. Another thing that is very commonly seen is atrophic vulvovaginitis. What this does is that there is intense vulval and vaginal dryness. This causes burning, tenderness, and pruritus in this area. Also, when there is urogenital atrophy, as earlier spoken by Sir, there is an urgency and frequency for micturition, this painful intercourse and painful urination and incontinence. There is no fixed treatment for this, but yes, a lot of topical creams can be used. Skin hydration creams are the treatment of choice. You can use moisturizers with collagen, with estrogen and peptides. Estrogen creams are FDA approved. Alternatively, platelet-rich plasma treatment also helps with the atrophy, helps in strengthening the skin and reducing the effects of burning and pruritus. Vulval lichen sclerosis, again, is very common, and the incidence of it also increases in postmenopausal women. There's marked atrophy and scarring in these individuals. The main signs that they come in with are saying that there's intraceable pruritus at night, there's very painful intercourse, dysuria is seen, urinary and fecal incontinence can also take place in advanced stages, and of course, painful skin fissuring and vulvodynia. So classically of the skin, you see a figure of 8 appearance. Initially, what happens is you'll see the patient will complain of tiny bumps on the skin, which are involving your labia majora and the genital folds. Gradually, as the person scratches these bumps and removes them, or you feel like excoriating them, it leaves a white patch there of scarring, and these patches usually increase, coalesce, and form big 8-shaped patches. Lacerations, bleeding, and scarring also develops if it is not treated. Looking at the treatment options, taking you quickly through them, potent topical corticosteroids are the treatment of choices. Newer pimecrolimus and tacrolimus works wonderfully, but it can cause burning. So you ask the patient to keep the tube in the fridge, avoid rubbing the creams when you apply them, and only dab the creams on. Symptomatically, lignocaine also can be used. Systemically, along with oral corticosteroids, oral antihistamines also are given. When we look at procedures, fractional lasers work wonderfully to improve the quality of life, and also intralesional steroids. So we use fractional lasers along with your topicals for added benefits. Surgery is usually reserved only if there are cancerous changes, and counseling, I feel, is the key for this condition. Coming to vulvodynia, we know that it's a widespread pain throughout the vulvar region, and the pain is usually constant or unprovoked by touch or pressure to the vulva. Intercourse or activity, of course, does worsen the symptoms. So they usually come in with poking or burning sensation. The skin is red, it's very inflamed to touch. They don't let you touch the skin in this area. There are various causes for this, taking you quickly through them. Neuropathic causes, chronic yeast infection, previous vulval skin disorders, hormonal changes, of course, causing the dryness is one of the major things that causes an increase in this condition. And of course, emotional stress and other allergies and infections. When we look at the management, physical therapy, pelvic floor exercises are the key. We can use amitriptyline and other anticonvulsant agents, but they're usually reserved for severe cases. Again, regular application of local anesthetics, soothing moisturizers with lignocaine, peptides, and collagen help in strengthening the skin in this area. Coming to hirsutism, which is the most troublesome skin feature, and actually most of the people who come to my OPD are troubled with the hirsutism. Either there's growth of hair on the upper lip, on the beard area, or on the side locks. And psychologically, it affects us a lot because how much can you go in for threading, how much can you go in for waxing or bleaching in these areas. Hormonal therapies seem to be the mainstay of treatment here. Of course, DIY hair removal methods offer temporary relief. Eflornithine hydrochloride cream works very well, especially over the upper lip. However, if your hair is already white in this area, then the results are not very promising. Laser hair reduction, again, a very good treatment option. However, they only target pigmented hair. So again, if you have white hair in this area, it's not the treatment of choice. For white hair, if you ask me what's the treatment of choice, is surgical removal, or we use radio frequency to create a tiny hole around the hair and then we pluck the hair out. So you're permanently removing the root in this area. There are a lot of other oral systemic agents like anti-androgens, spironolactone, and flutamide being the best, enzyme inhibitors like finasteride, and of course metformin to regulate the metabolism change that is happening. Another very, psychologically impactful thing is the alopecia that comes on with menopause. And you can either have a male pattern hair loss, which is usually seen at the sides, a female pattern hair loss, or Christmas tree hair loss is what we call it when it's seen along the center. And of course, a lot of autoimmune conditions like alopecia areata can be triggered. When we look at the management of it, understanding what is happening, seeing whether there are any vitamin deficiencies is key. Of course, supplementations with biotin and calcium pantothenate play a very big role in this. There are systemic anti-androgens that can be given. Finasteride and dutasteride are my treatment of choices. They work wonderfully. Finasteride at a 2.5 to 5 milligram dose and dutasteride as required. When we look at the topical therapies, as we see in this beautiful patient, we've used minoxidil 5%. It works wonderfully. It works as a vasodilator, and it also promotes your hair follicle to produce more hair. And usually, once minoxidil starts, it needs to be used lifelong, and once a day application is needed. When we look at peptide serums work wonderfully in improving the quality of your hair. So during menopause, a lot of people say their hair is becoming dry, it's becoming frizzy. The color of the hair is also lightening. So you won't have white hair, but that black is not looking very jet black. And peptide serums are key here. So Redensil is my personal favorite and it works wonderfully. Of course, platelet-rich plasma and growth factor concentrates are what we do the most in today's time for menopausal women, and it helps in beautifully in just, it's like cropping, and I say it's like growing a crop. For PRP and GFC is like adding a fertilizer so that you get a beautiful flower coming out, and that's how it works for your hair also. It just strengthens your hair and it promotes your hair growth. Okay, when we look at hair transplant for individuals where topical treatments and systemic treatments are not a choice, hair transplant works wonderfully. We take hair from the donor area at the back. And as you see, once we put the flap down, you can't even make out that you've taken this area. And there's a significant improvement in most cases. If you see this lady, she had a female pattern hair loss along the center, and we did a hair transplant to cover up this area. This is another individual where we did a hair transplant to cover up the central frontal alopecia. Now coming to the most common, I think it's seen in about 70 to 80% of women, which is flushing. Suddenly there's an intense heat and rapid heartburn feeling that we see. And on the skin, you can see erythema or redness. Sweating is also associated with it. And also sometimes throbbing pain is seen in the head and the neck. Usually the duration is 1 to 5 minutes, but the flushing can last for up to 1 hour. The treatment of choice here, of course, is lifestyle changes. So avoiding your triggers like caffeine, hot drinks, chocolates, meat, red meats, spicy or hot foods, and alcohol. Again, there are a lot of bioflavonoids and lignans that can be used like soy and red clover that mimic estrogen and help in reducing the flushing. Hormonal therapy and non-hormonal therapy can be given. And a lot of miscellaneous drugs like serotonin, selective serotonin reuptake inhibitors and paroxetine are being used. However, not very common. When we look at the skin changes due to hormone replacement therapy, basically there is nothing that directly comes in because of the therapy, but a lot of other pre-existing skin dermatoses also are worsened. The most common are eczema and metabolic facial pigmentation. So if you see this individual, eczema randomly over the shins, over the hands, basically the dry areas of the skin become worse. In this other individual, she has pigmentation all over the forehead. So this is classical metabolic pigmentation with a worsening of melasma, which is seen on her cheeks and nose. Again, there's an increase in skin tag, seborrheic keratosis, and the treatment of choice here is CO2 removal. So refer the patient to a dermatologist. It really helps them psychologically, because once those marks on their face improves, they also feel much more confident and happier to get out and move about and do their day-to-day chores. Another interesting thing is darkening and increase in number of melanocytic nevi. This is typically again seen during pregnancy, and post-pregnancy, this is seen again during menopause. So either the number of nevises increase rapidly, or they increase in size, or they increase and they become big and they become darker in color. So here again, the treatment of choice is either the Q-switch Nd:YAG laser or the fractional CO2 laser. As we see in this female, she had a big nevus on her chin. So we've removed it with the CO2 laser, and we can see after 8 weeks, the healing is beautiful with a very, very minor pigmented scar. Melasma, again, it starts by your 40s and it worsens in the 50s and 60s, typically seen over both the cheeks and the nose. The treatment here, and the key to treatment here, is sun protection, whether you're indoors, whether it's cloudy outside, whether you're not going out in the sun and you're only in front of your TV or your mobile screens, sun protection is the key. So applying sunscreen, applying 2 finger lengths of sunscreen for the entire face and reapplying your sunscreen every 3 hours is very important. So I think in today's talk, I want to request all the women out here that if you either tell your patients or you yourself, please start using sunscreen. Sunscreen will help in preventing all the UVA and the UVB induced skin aging, the extrinsic skin aging, and it helps a lot with the pigmentation changes as well. When we're looking at treating pigmentation, we can use various creams like kojic acid and glycolic acid. And of course, oral tranexamic acid works beautifully in postmenopausal women for melasma. When we look at the skin changes in menopause, the main goal is to improve the aesthetic concern and the function and enhance also the sexual experience of the individual. Feeling good in your own skin. And in today's time, the patient is aware of all the treatment options that are there. They Google, they see, okay, this black spot is melasma, this spot is a skin tag or is a mole. So they're already aware of it. But yes, we can give them, a basket approach and a complete package when it comes to their concerns. So usually what I do when I have a female coming in their menopausal period, if they've not already seen a gynecologist, I refer them to a gynecologist just so that, we can get a check in what's happening with them hormonally, and also seeing the gynecologist is the best, of course, to see whether they need hormone replacement therapy or whether they're on any other oral contraceptive pills or any other hormonal therapy. And of course, before I start my androgens like finasteride, flutamide or dutasteride, I always have a gynecologist consultation to see whether it's okay to start these. So I think combination treatment is the key here, and it enhances your results. And we know that menopause has a very negative impact on the quality of life, especially psychologically. So we need to make sure that we, the need of the hour is for you to be familiar with the skin changes that is taking place in a menopausal woman. And attention needs to be given to refer these cases to a dermatologist. So recently, I was part of a discussion with my colleagues, and they were discussing ways on how to treat the skin conditions. And I noticed that, I was just telling them that it's a basket approach and we can refer to each other. And actually that helps in extending optimal care to our patient and giving them the best results. Thank you so much. And I hope this talk was informative.
Thanks, Natasha. Your presentation is very good.
Thank you, sir.
Covering the treatment part also.
Thank you.
Very good.
Thank you so much, Dr. Bin Singh, for taking out your time, and Natasha, wonderful presentation. So over to you, Sangeeta, to introduce Dr. Hepsi.
Yes, sir. Good evening, everyone. Since morning, now it's good evening. At the outset, I would like to convey my regards to Shobhana ma'am as well as Sudhaa Sharma ma'am. And I would like to thank Ragini ma'am for giving me this opportunity to interact with stalwarts of IMS. And really, it's my pleasure because Ragini ma'am is in my rag. Just like randomized controlled trials, always Ragini ma'am bang with amazing academic feast, and today also she has proved it. And now it's my pleasure to introduce Dr. Hepsiba ma'am, who is going to speak on mental issues, and she will tell us how our pelvic brain system, which is consisting of uterus and ovaries, will control the central nervous system. Dr. Hepsiba ma'am is a gynecologist in St. Thomas Mount, Chennai, and she has an experience of 39 years in this field. She practices at Thomas Hospital as St. Thomas Mount, Chennai. She completed MBBS from Stanley Medical College, Chennai in 1977. She did her MD Ops and Gynae from Madras Medical College, Chennai in 1983 and DGO from Madras Medical College, Chennai in 1979. She has got many awards and she has publications, so many. And Madam came to Amritsar when she installed her book on clinical aspects for the UG students, if Madam remember me, because we introduced her book in front of our UG students. Over to you, ma'am.
Welcome, FC.
I thank the organizers for giving me an opportunity to share my thoughts. And I should congratulate Dr. Ragini for the wonderful webinar, and the selection of topics is too good. We are glued to the seat from morning, right? Congratulations to the entire team. So when the topic is given to me, few questions came to my mind. What is mental health? What are the mental health changes during aging? What is its incidence, impact? What is the symptom? What is the risk factor? What are the approaches? How to approach and treat them? So coming to the definition of mental health as per WHO, it is a state of well-being in which the individual realizes her own abilities, can cope with the normal stresses of life, can work productively, fruitfully, and is able to make a contribution to her community. That is mental health. So there are a lot of changes happens with the aging. Our neuropsychiatric and IQ remain stable till 80, but the psychomotor speed decline, simple recall decline, and the brain decreases in size by weight by 17. By 80 years, the ventricles enlarge, decrease in cerebral blood flow. So again, there is a relationship with the menopause and aging. The brain and ovaries, as already mentioned by our chairperson, it's a part of neuroendocrine system, and the hormones directly affect neurotransmitter. And the estrogen, estradiol, is a neuroprotective and plays a very important role in stimulating neurotransmitter, which is especially involved in mood. And estrogen is a key in energy production in brain and at cellular level, and E2 encourages neurons to absorb glucose so they can make energy. And there is a 30% drop in energy level at the time of menopause, which is the one which causes brain fog. And similarly, the progesterone is neuroactive. It enhances the GABA receptor in brain, and it is considered as an inhibitory neurotransmitter because it inhibits certain brain signals and decreases the activity in nervous system. So coming to the incidence, at least 1 in 5 women suffers from depression during menopause. Women with personal or a family history of depression are particularly vulnerable. Menopause may trigger schizophrenia, bipolar disorder, anxiety, panic disorder, and especially when they're already predisposed to mental illness. So how it gets affected in age, either by directly or indirectly. Directly by the hormones, the mental health can be directly impacted with the declining hormones, especially estrogen. The sex hormones as a neurotransmitter, which is involving in controlling the mood, and indirectly by our menopause symptoms like hot flushes, insomnia, low libido, muscle and joint aches, decline in mental agility, and urogynec symptoms also indirectly affect our mental health. And other factors, that is, it starts from midlife onwards. That is, we always call the midlife people as a sandwich generation. The demands of growing children on one side and entirely parents, and the financial and career changes also takes place. getting older in society that values youth, we feel about it, worries about health of a partner, so on. So many other factors also influence our mental health. So the changes in physical health also may can, suppose they have a thyroid, already they have that drugs and also certain things, and the anxiety may be triggered by an overactive thyroid gland, and some medication, multiform therapy may be there, that also will spoil the mood, can cause the mood disturbance. The various disorders which we can come across is the cognitive decline, either a dementia or delirium, and psychotic mood symptoms like depression, anxiety, mania, and substance misuse and addictive disorder, medication, and sleep, eating disorder can happen in old age. So this is the common psychological symptoms, that is mood disorder, depression, difficulty in concentration, memory loss, and fatigue, irritability. This can start either worsening of pre-existing mental health, or it can emerge as a new onset symptom also. So coming to the symptoms, these are all the modest list of symptoms, like they feel sad, tearful, loss of interest, trouble in concentrating, lapse in memory, and sleep. Either they can sleep too little or too much also is a sign of depression. Changes in our appetite and unexplained physical pain is all signs of symptoms of depression. And brain fogging, very often we get that symptoms. We will be talking to some person, that lady, that day she came, in that meeting. We will not be able to, this is how the conversation will go on. We will not be able to complete the sentence. It really affects our confidence, and they cannot order the thoughts in a proper way. And another thing is the forgetfulness. When a mind caught up with worries, fear, anger, they are not mindful at present. There are too many things is confusing in your mind, and they will not be able to remember small things. So anxiety, again, a panic attack can happen in menopause. The sudden sense of extreme anxiety accompanied by sweating, trembling, shortness of breath, and palpitation. So we may get confused with the vasomotor symptoms. So hot flushes. So the one thing differentiating point is in panicky, they feel short of breath. That's how we have to differentiate. And this is again, the old people will have a habit of collecting everything. They may even neglect the personal and environmental hygiene. Even if somebody, they will collect all rubbish, and they will not, happy to part with that. So even somebody is trying to help them, they will not. This is one disorder. They will be collecting so many things and encroaching most of the living space also. So sometime late life psychosis can happen. Late onset schizophrenia, very late onset schizophrenia, delusion disorder, psychotic and psychoaffective disorder, and finally dementia. And few of them, they can have an drug-induced. So how do we approach? Like any other disease, we have to take a detailed history. The family history of mental health is important. History of premenstrual tension is important, and other medical conditions we should elicit, vitamin deficiency, and about the drug and alcohol, and work and life balance, how they behave in a work, and that who do they live with, what else is going on at home or work. All these things we have to elicit, and we should find out whether they are able to cope up with the function, or they need an urgent referral to the psychologist support. That is how we have to approach the patient. As already mentioned, everyone is talking right from morning. The physical activity increases the blood flow to the body, including brain. So 150 minutes week, a moderate aerobic activity. If 75 minutes of week of vigorous aerobic activity is very good. So even if we don't have time, we have to steal time, and at least 10 minutes we have to walk. So this is actually, it is evidence-based. Very good exercise. So as already mentioned, we have to take a proper balanced diet with a protein and a low glycemic index and plenty of water. And we have to be mentally active. The physical activity helps to keep your body in shape. And when you give some activity, your brain will be, your memory loss will be less, and keep your brain active. We have to develop new hobby, or we have to get involved with people. So we have to keep our mind alert. And the sleep is very, very important. Nearly 7 to 8 hours sleep is very important. And we have to socialize regularly, especially when we are alone. The children go away to the abroad and both of us living together. And so when we feel lonely, if you get socialized regularly, then your mind will be alert. So your mental health will be more. And we have to look after the chronic condition and take the proper medication. And certain various medication also can affect memory. So you have to consult your doctor and then set it right. So we have to stop all this abuse things. And we have to live for our own self. Self-care is very, very important. Look at these two images. She's not bothered about anything, simply taking the tea. But this lady is having a pet dog with her, and she's enjoying that particular cup of coffee and something she's looking at in the computer, so that she feels very happy. But this lady, she's not bothered about the environment at all. So we have to enjoy the nature also. We have, when we go for a drive or something like that, we can stop a while, look at the sunset or sunrise. So we have to do all these things, and certain habits we have to develop. If you develop certain new habit, you will not forget. See, for example, if you take a medication as you are feeding the fish, that becomes a routine and you will not forget about it. These are all the few things we have to take. And of course, we have to take supplements, especially vitamin D, calcium, and all these things will helpful. Sometimes the way we have to manage stress, either we have to go in for meditation or yoga and take a deep breath to reduce our stress. So when a patient comes, we have to assess. There are a lot of scales to assess, even for depression, anxiety, and other things. We have to take a decision whether they need an active psychological treatment or maintenance therapy, or to treat ourselves. So this is very important. And when you decide about menopausal hormone therapy, especially is indicated when they have a associated menopausal symptoms. Suppose if they have a vasomotor symptoms and they don't have proper sleep, then your menopausal hormone therapy is going to, because of that, they get depressed, lack of sleep, then you can give menopausal hormone therapy. So there is a sexual dysfunction because of vulvovaginal dystrophy, then you can go and treat them with a vaginal estrogen. But we can start them on antidepressant. It depends upon the analysis of so many scales and other things. But when they start, this is the general rule. We have to start with a start with a low dose and go slowly, because in older age, the side effects are more because they retain, and GFR is very less. So hepatotoxic, renal toxic will be there. Sometimes they require SSR, SNR, non-adrenergic specific antidepressant. Also, they may require amitriptyline. They're all, but with the concurrence of psychiatrists, we should prescribe them. So what we should do? So they may not come and tell us that they have this depressive symptom and sleeplessness. So we have to ask them and find out and listen to them. And we should have a holistic approach, both pharmacological and non-pharmacological option. Counseling is very, very important. Certain things we can prescribe. A leaflet can be left in our clinics so that we can give it to our patient. So the 10 commandments for mental fitness is physical activity, stay mentally active, socialize regularly, get organized, keep the memories alive, and sleep well, and eat healthy diet, manage chronic conditions, limit the bad stuff, form a habit, and take supplements. So slow, deep breathing is important. It is like an anchor in the midst of an emotional storm. The anchor won't get rid of the storm, but it will hold you steady until it passes. So similarly, training your mind to the present moment is the one key to making healthier choices. Being able to be your true self is one of the strongest components of good health. I would like to show the small thing which I have directed and my student, how we can change from forgetfulness to mindfulness. So thank you for patient listening.
Hepsi, this is the whole steps of the full 9 to 6.
Yes, ma'am.
Showstopper video.
And I knew that you can only do it. That's why you came at the last.
That's very much.
Excellent, amazing, awesome, ma'am. Excellent. Hats off to you. Excellent and amazing meeting. Thank you so much, ma'am. And one word I want to add. तन जितना भागता रहे और मन जितना स्थिर रहे उतना बेटर.
I can't. I know thoda Hindi.
You don't do such poetic Hindi and all to her. Make it simple English.
Simple English means our body should work all the day. Something we have to do all the day, but our mind and soul should be stable.
Yes. That's right.
So I think, thank you so much, everyone.
Yeah.
We had a wonderful
Thank you.
time. And this next year again, this MMLCON will come with some new theme. And thank you, Deepika. It's always wonderful to working with you. Over to you to finish it off.
Thank you all.
Bye, Dr. Shobhana, Ragini,
Thank you, Deepika.
Hepsiba.
Thank you, Sudhaa ma'am.
Thank you, Ragini, Dr. Shobha.
Bye, Sangeeta.
Sudhaa.
Bye,
Thanks
everybody.
from Jagsonpal as well.
Shobhana ma'am.